We'll be starting today's proceedings, and today Department of Neurology is presenting, and from that Unit 3 is presenting a fine balance, unraveling a new treatable ataxia. So I will request yes, please.
Good afternoon, respected faculty and my dear colleagues. Myself, Dr. Farsan, I will be presenting the CGR for Department of Neurology. Topic is fine balance and unraveling a new treatable ataxia. So, the outline would be the case summary of cases with their videos and the diagnostic evaluation and a discussion. So, straightforward, moving to the first case. So, here we have a Mrs. Hay. She is a 37-year-old female and homemaker. So, she started having sudden onset episodic vertiginous sensations with no postural variations 10 years back. And she also started having insidious onset imbalance while walking and smearing onto face while eating. That started 10 years ago, that at her 27 years of age. And symptoms progressed over 5-year period with occasional exacerbations and remissions with a febrile episode. And then she improved her baseline status of a few months, and for a span of 1 year, she remained totally asymptomatic. And then again, from the 33 years of age, patient started having insidious onset progressive imbalance while walking and difficulty in speech and smearing onto face while eating. So she had, as I told already, she had a worsening of symptoms with fever and no seizures, paroxysmal movement disorders, or exposure to toxins or medications, no weakness of upper limbs or lower limbs, or any sensory symptoms or any slowness or stiffness, and no constitutional symptoms like loss of weight or loss of appetite, diarrhea, bowel bladder incontinence, or chronic cough. So, personal history mein, she was vegetarian by diet and bowel and bladder habits were normal and no history of any substance abuse. Her family history was not significant. On examination, general physical examination was not showing parallel cyanosis, clubbing, lymphadenopathy, pedal edema, no cataract, pinicula, white spots, telangiectasias, retinitis pigmentosa, tendon adermas, or pescaris. And her vital signs were within normal limits. Her blood pressure was not showing any postural drop, and her systemic examination was also within normal limits. We'll move forward to the examination videos. So here we can see the speech sample. So she was having a scanning speech, and in the next segment we can see the case of nystagmus. On the right case and towards the left case, we can see the gaze of nystagmus. And you can see the hypermetric saccades with the gaze of nystagmus in the oculomotor system examination, and her reflexes were elicitable. In the upper limbs, the reflexes were just elicitable, and in the lower limbs, we had a brisk knee jerk with a absent ankle. Even after gymnastics maneuver, we couldn't elicit the ankle jerk. Higher mental function examination was normal, and other cranial nerve examination was also within normal limits, and her bulk, tone, power were normal, and sensory system examination, extrapyramidal system examination was normal. So we made a clinical impression of 37-year-old female, initially had a vomiting ataxia with episodic vertigo, preceding this chronic progressive pancerebellar syndrome with peripheral neuropathy. So it was a chronic progressive course. If we analyze the episodic vertiginous sensation, which were recurrent and associated with imbalance and gaze of nystagmus, with no much peripheral symptoms like nausea, vomiting and all, the cause could be probably central. and we had a remitting ataxia. So it differs slightly from the episodic ataxia. The classical definition of episodic ataxia would be ataxia lasting for hours to days. So as it persisted for extended period. Actually, this patient had a ataxia which lasted for a few years before she improved, rather than occurring in the short discrete episodes. So we call it as remitting ataxia, and she had a pancerebellar syndrome where the gait ataxia can be localized to vermis, appendicular ataxia can be localized into bilateral cerebellar hemispheres, and speech can be localized to left paravermis, and with the peripheral neuropathy as she was having hyporeflexia. So the etiological possibilities that we considered in our case was the treatable causes at first. We thought about nutritional causes like vitamin E deficiency, B1, B12, copper deficiency, and autoimmune and inflammatory causes like gluten ataxia can have some remitting, relapsing cause, and endocrine and other systemic causes like hypothyroidism, hyperglycemias, and hereditary ataxias, of course, we have thought about, like autosomal recessive ataxias like Friedreich's ataxia, ataxia telangiectasia, and ataxia with oculomotor apraxias, and also autosomal dominant scar with peripheral neuropathies and some mitochondrial disorders, as this was a remitting ataxia. So her NCCT head was not showing any cerebellar atrophy. Also, her MRI was also not showing any cerebellar atrophy. It was normal MR. And these were the causes. These were the evaluation that we have done for the treatable causes, where we can see the thyroid profile and anti-TPO was within normal limits, and B12 folate copper levels were normal, and tumor markers were normal, and also the NCS was showing the sensory motor axonal neuropathy involving bilateral lower limbs. So this is our first case, and then I'm directly moving on to a second case. So he's Mr. B. He's a 24-year-old male. He was a shopkeeper by occupation. So his course is like he had a history of fever with chills and rigor and myalgias at 14 years of his age. So this lasted for about 5 days. And this fever unmasked actually some symptoms. That is 3 months after this fever, he could recollect that he started having insidious onset of falls and imbalance while walking. And he started having tremors in his bilateral upper limbs and neck since the age of 16 years. And he started having the other symptoms like smearing onto face while eating, difficulty in speech. He was having the splitting of syllables while speaking since the age of 20 years. As you can see by the figure, it is a gradually progressive course. So here is the video. The first.
Or or
So first segment we have seen the scanning speech, and he also had the hypermetric saccades. And you can see some dystonia and dystonic tremors involving the neck. And he also had bilateral finger nose finger test positive and dysdiadochokinesia. This is the gait video where you can see the gait ataxia. And he also had this dystonic posturing and dystonic tremors involving his bilateral upper limbs and also the neck. So here we had made a clinical impression of a pancerebellar syndrome with dystonic tremors involving the bilateral upper limbs and neck following a febrile illness. So this disease was unmasked by a febrile event. And it would be a syndromic diagnosis of pancerebellar syndrome. We had already told the localization for the pancerebellar syndrome and dystonic tremors plus dystonia. So dystonia is the stereotypical sustained or repetitive non-suppressible movement, and which could be associated with sensory tricks and overflow phenomenon. So here the dystonic tremors usually occur in body parts affected by the dystonia specifically. This dystonic tremors can be asymmetric and irregular. So here we have kept the possibilities of some degenerative and genetic cerebellar ataxia. This is it's a very progressive course, and the duration was also very long duration. So it was unmasked by fever. So we thought about some autosomal recessive ataxias where you can see this dystonia also. So in ARCA type 2 ADCK3 mutation, dystonia can be associated, and ARCA type 1 SINE1 mutation, rarely dystonia have been reported. and ataxia telangiectasia, ataxia with oculomotor apraxia and ATC. And we also thought about the fragile X stromal ataxia syndrome. And the other disorders that we should keep in mind would be the mitochondrial disorders and the treatable causes also we have considered here, like the nutritional causes, vitamin E, B12 and copper deficiency, and autoimmune and inflammatory causes, and endocrine and systemic causes also considered. So this was the brain MRI, which was showing the marked atrophy of vermis and also the cerebellar hemispheres, as you can make out. So this is the T2 sequence, and this is the sagittal the T2 sequence, which is showing this diffuse atrophy, and even there is gliotic changes involving this cerebellar hemispheres, and vermian atrophy can be also. So these were the investigations as we worked up for all the reversible causes at first, and all the reversible causes came out to be negative. So I'll be describing our third case. He is a Mr. C, 26-year-old male. He had delayed birth with a poor scholastic performance, and he had a history of one episode of fever and altered sensorium and unknown onset generalized tonic-clonic seizures for 1 week duration at the age of 7 years. Thereafter, the seizures continued at a frequency of once in a month, and he started, after this fever event, he again started having imbalance while walking since the age 7, and it was also gradually progressive. As you can see, as depicted by the diagram, the imbalance was also gradually progressive, and he became wheelchair bound by the age of 18 years. So at the age of 11 years, he started having myoclonic jerks, which I'll show in the video, and he also started having smearing onto face while eating and difficulty in speech at the age of 16 years, and cognition was gradually preserved. But the specific history that he gave us was that he noted improvement in his functional status during fever. So as senior residents, we were rechecking the history again and again, whether it is worsening during fever or an improvement during fever. But he was very confident in his history. So he was telling he had noted this improvement in functional status during fever. So this is the speech sample. So you can see a severely ataxic speech. Slow pursuits were normal, and he had a areflexia. His reflexes could not be elicited. Even after gymnastic maneuver, reflexes could not be elicited. And he also had this positive finger nose finger test and dysdiadochokinesia. So here you can see some myoclonic jerks involving his upper extremities. Along with that, you can see the impaired finger nose finger test. And he's having this occasional myoclonic jerks. We couldn't elicit much stimulus sensitivity here. Here we can see the myoclonic jerks more clearly. So here we had a patient with a syndromic diagnosis of progressive myoclonic epilepsy with ataxia and peripheral neuropathy. So we had epilepsy which was well controlled actually, the seizures. It started as an unknown onset tonic-clonic seizures, but thereafter he was controlled with anti-epileptic drugs. And he also had a peripheral neuropathy phenotype, and this was also gradually progressive, but his symptoms mainly consisted of this ataxia, and he also had this improvement during fever. So considering that in PME syndromes we have reviewed this KCNC1 related disorders, which can present like a myoclonic epilepsy, ataxia due to potassium channel mutation, which is the PME type 7, can have some improvement of the symptoms during fever. And the next possibility we kept was the MERF, sialodosis, DRPLA, NCL, and the other treatable causes were also kept in the differentials. So for him also, this was the MRI brain, which was showing marked cerebellar atrophy and also Vermeer atrophy with no signal changes in the brain parenchyma. And these were the investigations. We thoroughly investigated for his PME phenotype and also the treatable causes of the cerebellar ataxia. His CK was normal, his fundus was not showing any cherry red spots, or there was no lephora bodies in the light microscopy from the axillary skin fold biopsy, and NCL inclusions were also not found in the electron microscopy. And we had some findings in the NCS. He had a sensorimotor axonal neuropathy involving all four limbs, and I'll show you the EEG. So EEG was showing generalized spike and wave, polyspike and wave discharges, and SSCP was done, which was normal. So this is the case 4, which was Mr. N. He's a 56-year-old male. So as depicted, he had a progressive pose. So he had a 10-year history of imbalance when walking and facial smearing and speech difficulties. And he, on examination, he had slow saccade, cerebellar dysarthria, and bilateral finger nose finger test positive, gauge ataxia. His reflexes were brisk and plantar were flexor. And he had a family history of cerebellar ataxia in his father. We couldn't phenotype him. And the impression was a spastic ataxia syndrome. Here we had a pancerebellar syndrome and also spasticity, which was a chronic progressive type of disease. And the etiologies that we have considered were the autosomal dominant spastic ataxia phenotypes, especially the SCA1, 3, and autosomal dominant hereditary spastic ataxia with cerebellar signs, and optic spastic ataxia with optic atrophy, and adult onset Alexander's disease, and other treatable causes also we have considered in the differential. So here is the MRI brain again, which is showing only very mild atrophy, and it is almost normal. There is no signal change in the brain parenchyma or in the spinal cord. So these were his investigations, where we have done the workup for the usual treatable causes of ataxia, which was negative. And then we had a case 5, which is Mr. M. He's a 61-year-old male. He was an advocate by occupation. So this is the clinical trajectory. He had sudden onset recurrent episodes of dizziness with mild blurring, nausea and imbalance while walking, and tremors in the upper limbs when reaching out for objects, which was lasting for approximately 45 minutes since the last 8 months. So the duration of episodes actually progressed from this 45 minutes to 2 hours over the last 2 months. And on examination, even indirectly, we could find some downbeat nystagmus and mildly impaired straight line walking test indirectly, but there was no myokymia or any orthostatic hypotension. So here we had an episodic ataxia phenotype. So this is the definition according to Griggs and Spacey and Carpati. So they have defined this recurrent attacks of ataxia, which is lasting for seconds to hours and with an indirectal normalcy. But some patients, as depicted in our case, might have some mild ataxia or nystagmus. So we have considered all the causes of episodic ataxias, and episodic ataxias with other genetic disorders we have reviewed. From there, we could find out that SCA14, SCA27 and 35 and GLUT1 deficiency was also kept as differential. And the other possibilities we kept were mitochondrial disorders and the metabolic disorders like amino acidopathies and urea cycle disorders, thyroid metabolism disorder, vitamin metabolism disorder. So this was the MRI brain. Here there is no much atrophy, it is normal, and there is no signal change in the brain parenchyma, and also spinal cord was normal. So these are the investigations that we have done. We have done the magnesium serum electrolytes and everything came out to be negative, and also the reversible causes workup was negative. So this is the 6th case, which is the last case, where we have Mrs. Y, and 50-year-old female. She is a homemaker by occupation. She had a history of fever for 4 days, that is 2 years ago, after which she started having imbalance while walking and a slurred speech and tremors in upper limbs. So this lasted for 1 day and subsided completely. So after 7 months, she again started, had a history of fever for 5 days and started having difficulty holding utensils. And she also started having swaying to either sides while walking. And these symptoms lasted for 45 minutes and recurred in every 15 to 25 days. So her trajectory was also like she was having these fluctuations. And over the past 11 months, these episodes become more prolonged and progressive. The interesting fact is that she had a positive family history in her brother and her father. So both had gradually progressive ataxias. We have to phenotype them. So this is the examination video where you can see the speech sample. So she had a scanning speech. We can see a subtle downbeat nystagmus also. And her vertical saccades were normal, and she had some slowing in the horizontal saccades with a downbeat nystagmus in her examination of oculomotor system. And pursuits were normal. And she also had brisk reflexes. Both in the upper limbs and lower limbs, she had brisk reflex. So you can see the knee jerk, which is brisk. And even her ankle jerk was also brisk. Plantar were flexor, and she had a positive finger nose finger test and a positive heel shin test bilaterally. And you might have observed a nasal twang also to her voice. And this is a gait video. So we had made a clinical impression of episodic ataxia triggered by the febrile episodes, followed by the subacute progressive pancerebellar ataxia with a strong positive family history. So here we have considered this episodic ataxias. Actually, this EA2, which is a calcium channel mutation, can have initially episodic episodes and then going to a chronic progressive course as a clinical trajectory. And rarely episodic ataxia type 1 can have such a presentation. And the other differential was SCAR6 overlap with EA2, and SCAR27B was other differential, and GLUT1 deficiency, and of course the mitochondrial disorders we thought about. So this was her MRI brain, where we can see the mild atrophy of the cerebellar hemispheres with no signal change in the brain parenchyma or the spinal. So her causes were also reversible. All reversible causes were also worked up, including the mitochondrial. For mitochondrial etiologies also, serum lactate was normal, SCK was normal, and all the reversible workup was negative. So here, all these patients, we had sent the SCAR panel. You would be interested in the SCAR panel, so which comprised of SCAR 1, 2, 3, 6, 7, 12, and 17, and also the Petraeus ataxia panel came out to be negative. So are these phenotypes just different phases of same genetic disorder playing a game of molecular mask? So this is the question of the day. To our interest, we had the third patient who had a PME phenotype. He came to us with a whole exome sequencing report, which was showing a pathogenic mutation in the PME7 phenotype, that is the potassium channel gene mutation in a heterozygous state and with autosomal dominant inheritance. So are we sorted out with this? So we have something to reveal yet. So who is this new kid on the ataxia block? That is another query. So all of the patients had SCAR27B, FGF14, GA repeats in the pathogenic range, which is the intronic GA repeat expansion disorder. So these were the reports of these patients, where you can see the allelic frequency. So to categorize this disorder as pathogenic, we have to have this allele frequency at a range of more than 250. So here you can see these two patients, the case 4 and the case 6, which was a severe phenotype which had a rapid progression over to the remitting disease, which had a rapid progression as a severe phenotype, had a biallelic expansion of her gene. And then this case 4, who also had she also had a family history, strong positive family history in her brother and also her father. And the fourth case also had a progressive ataxia phenotype, where he also had a family history positive, had a biallelic expansion of this FGF14GA repeats, and the rest all were heterozygotes, where one allele had more than 250 repeats. So what was the technique which was used for this? So to testing, we had to detect this expanded FGF14GA trinucleotide repeat expansion. It was performed with this triplet prime PCR, and if the alleles have GA repeats more than 100, detection of exact GA expansion repeat length was performed with the long range PCR. So this is the methodology where we initially for preliminary screening, we do a flagging PCR and then repeat prime PCR and long range PCR, and eventually we have to do a long read sequencing to detect this intronic repeat expansion. So this is the long read sequencing technique and repeat estimation, which was confirmed by the computational analysis. So we had treated around 6 patients with some symptomatic therapy. We were not very sure about the etiology of this disorder. So we had given amantadine for our first patient, and for dystonia, dystonic tremors and all, we have given propranolol and trihexyphenidyl. And the third patient, who was a PME phenotype who had a seizure, we have given zonisamide, valproic acid, and clobazam, amantadine. And he had improvement in myoclonic jerks, but his ataxia was static, and it was there in the follow-up also. And the fourth patient, we have started amantadine, and fifth case was a classical episodic ataxia phenotype. We have continued him on Dimox. He had a moderate improvement, and sixth case, we have again given amantadine. So these are the treatment trials which for SCAR27B. So 4-aminopyridine is tried in this. It was tried. This article was published in Brain. So here they have noted in one family cohort improvement in diplopia, dizziness, dysarthria, and the impaired gait with 4-aminopyridine, which is a potassium channel blocker. And in another trial, we have to have some randomized control trials. Actually, we have very less number of patients detected with this mutation till date. So, and some therapeutic effect of acetazolamide was detected in 40%, and it was also, the numbers were very small to derive any conclusions from this. So, SCAR27B is basically due to the repeat expansion in intron 1 or FGF14. So, in contrast to SCAR27A, which is a deletion disorder, it is a intronic repeat expansion disorder, and it was having a positive family history. But in the French-Canadian cohort from which the first article was published, had a 15% of patients who are sporadic. And FGF14 expansion was considered as the major cause for this late onset cerebellar ataxias in all of these cohorts, where you can see the published literature, where you can see the most of the cases where the sporadic late onset cerebellar ataxias were undiagnosed cases. So some clinical clues to this disorder is that patient can have episodic onset, which would be lasting for a few seconds to few days, and majority of these patients can develop a permanent ataxia after 3 to 4 years, and some can remain as an episodic form even up to 10 years. So this is our experience on the screening of ataxia cohort. So here the total family screen were for 5,600. So among them, a large chunk is the uncharacterized ataxias, where we have 4,032 patients. Among the uncharacterized ataxias, we have all these etiologies, where we can also see the SCAR27B. In the Indian context, we have this article was published in the Neurogenetics in 2024, and here the SCAR27 frequency in the Indian ataxia cohort was about 1.83%, which was close to that of SCAR3 and Friedreich's ataxia. So they had the repeat expansion in the range of 262 to 645, and among them, this 5 patients had a biallelic expansion, and 2 patients had a homozygous repeat expansion. So, and most of the patients had a cerebellar atrophy, and some patients had normal cerebellum. And these were the findings. So the age was ranging from 4 months to 83 years. Here we can see a difference in our Indian context, that most of them are not the late onset ataxias. Even in the clinical cohort which I described now, have very young onset phenotypes, and the preliminary finding that with which they present to our clinic would be the abnormal gait, because the vermis is the first structure to get involved initially, which can manifest as gait ataxia. Eventually, the degeneration can happen in the hemispheres. So eventually, patient may develop perpendicular ataxia and the slurring of speech. So this was the GA repeat distribution in our SCAR27B positive patients in the study. So this was published in Neurogenetics. So this study highlights the necessity to screen the genetically unsolved ataxia for SCAR27B, as it is relevant to the other emerging ataxic disorders in India. So further investigations and there should be some case series or larger cohort. We have to phenotype them thoroughly, then only we can understand, we can pick them early. These are the largest cohorts which are described in literature. So you can see the French Canadian cohort, German cohort. So when our patients had a mean age at onset of 33 years, and the range is from 7 years to 61 years at the mean age of onset. So as I pointed out, it's a bit different from the outside scenario. So, and history of fever preceding onset was observed in 3 of our cases, and also this dystonic tremors was observed in one of our patients, and the peripheral neuropathy was there in 2 of our patients, and one patient had a nasal intonation to voice, the 6th patient, and she had a palatal weakness also. So these are the some difference of the findings and the new phenotypic characteristics of this of our cohort. So, what are these digenic disorders? They arise from this pathogenic variants in 2 distinct genes, both contributing to the disease phenotype. So, this KCNC1 with a Meek syndrome phenotype had this age of onset, like usually they should have the myoclonus onset between 6 and 14 years of age. Here, the myoclonus would be the prominent clinical feature. It will become very severe during adolescence and impacting mobility. But here, the ataxia was the initial presenting feature and the predominant phenotype with the onset of the disease. And he had a well-controlled seizures, and also he had a myoclonic jerks. So it could be a digenic inheritance in this case. And so up to 75% of the hereditary ataxia patients remain without a genetic diagnosis. So this recent advancements in bioinformatic tools and long read sequencing have dramatically enhanced our ability to uncover this undetectable repeat expansion disorders. So this really opened new doors for diagnosis and precision medicine. So among the promising breakthroughs, even 4-aminopyridine is emerging as a game-changer symptomatic treatment for SCAR27. These are some of my references, which you can go through later. Thank you.
So these were important cases in terms of few things, I will say. One is that there is a usual SCA behavior, spinocerebellar ataxia kind of behavior. And the behavior is that you have age at onset between 30 to 40 year age. I'm talking about usual SCA, 30 to 40 year age group. Gradually progressive kind of disorder, specifically ataxias, gradually progressive kind of. And the third thing is phenomena of anticipation. So these cases were quite different. One is that they had episodic pattern in the early part of illness, then there were progressive decline in the illness. And the other thing, you can see the age of onset. It varied from young to adult, not like between 30 to 40 year age. And the other thing which is very important, SCA usually is a kind of triplet repeat or some point mutation or something like that. But this had a long read sequence, means the usual sequencing procedure which we follow will not be able to detect this kind of ataxia. So you have to have this in mind. Earlier, these cases were there with us for years now, and they were in the unknown category. And with the development of this long read sequencing technique, now we are able to identify these. One important point again in this case, usually the spinocerebellar ataxia cases, nobody will complain of imbalance, nobody will complain of vertigo. Nobody will complain of vertigo. All will say that imbalance is there, incoordination is there, but nobody will have vertigo. So these cases may be recognized. One is by episodic behavior in the beginning and the prominent complaint of vertigo. Third thing is that history of fever, which is often preceding, not immediately, not like high grade fever and you develop ataxia, not like that. There is history of fever, and within 15-20 days, 1 month, you will develop some kind of ataxia which will last for again few days, few months, and then you will improve. This is some different kind of phenotype, and that is why I thought that it should be presented to all in the CGR and CC. Thank you so much. Any questions? Questions Farzana will answer. Oh.
So initially we were not sure about the diagnosis. We have started them on the symptomatic measures, and like some patients we have lost to follow-up, and most of them had mild improvement only. So we will be following them out for acetazolamide. In the last patient we had given acetazolamide. In the episodic ataxia phenotype, it had a moderate response to acetazolamide. So, we have kept him on that.
Yeah.
We have.
Yes. Only one. But let me tell you, I from the again, the same thing as yeah, the number of people which is also progressing except goes down. They are also finding however, in the literature, till now 250 and more number is
You talk about the ones which are producing more the neurons. Any other which is
yes. Charts.
RFC, sporadic late onset ataxia, cerebral ataxia, where there were a lot of RFCs and started design.
So I am sure the unknown chemically will gradually shrink. It's very 30%.
Korea understand it all. Almost
Mostly MSc has been yeah.
Thank you.